my friends had been asking me to write a cookbook for probably 15 years now. And I was just like, well, why would anybody want to read a cookbook that I wrote? Like, I mean, most of it's recipes.
Well, you must be a hit then, right? If your friends
Well, I mean, my friends like to eat, yes.
Welcome to VNEW Health, powered by Arms Medical. I'm Robert Greer, and today we're talking urology, lifestyle, and a brand new cookbook with Dr. Janelle Evans. Dr. Evans, she trained at Tufts, she completed a residency at UMass, and she did a fellowship at Christ Hospital in Cincinnati. She loves to travel, outdoor life, and takes cooking class on every trip. So, Dr. Evans, welcome to the show.
Hey, thanks. It's awesome to be here.
All right. So, Dr. Evans, Tiny-Giney, how did you coin that term, or where did that come from?
Yeah, so I coined it about 20 years ago, and it was right when I was starting med school, and or actually like 25 years ago now. But I'm pretty short. I'm just barely 5 feet, and I was going to be a gynecologist, so I just put Tiny-Giney together, and that's my email, and that's my website, and everything.
And it's followed you along ever since.
Yep.
All right. How did you get into wanting this pathway?
So with regards to medicine, I mean, I kind of always assumed that I was going to go into medicine. I took a little brief foray after my master's to work in pharmaceuticals and do some organic chemistry for a while, but the long-term plan was always to get into medicine. It didn't really take all that long once I got into med school to know that I wanted to be in a surgical field, so that kind of narrowed things down a bit. And then I did a rotation in my 4th year of med school with a female urologist in Boston, and basically just decided that, if possible, that was the route that I wanted to go. So ended up doing my residency in OB-GYN and then fellowship in urogynecology after that so that I could get that route down.
Fantastic. And so that exposure of both the surgical side of things as well as the women's health, what do you find to be the most rewarding in what you do on a weekly basis?
Yeah, I mean, I think, one of the wonderful things about urogynecology, and it's sort of like the secret behind it, is that most of the people that we see in the office, we can actually pretty much fix what's going on. I mean, it may not be 100%, but we can definitely improve, lifestyle and day to day for the vast majority of our patients. And I don't think that there's a lot of specialties in medicine that you can confidently say that. So it's really nice that way because you're actually doing a service that's going to make somebody's day to day life better. The other thing is that, and right now there's been a much bigger focus in it than previously, but just midlife women's health in general has gotten a lot of additional press lately, and that's really what we do. Some of us do more of the hormone therapy piece and the more lifestyle counseling piece more than others, more just focus on kind of the sequelae of having babies, which do a number on your body, and then we fix what goes wrong after you have the babies. So everybody has a little different focus on what they want their specialty to look like. But for the most part, the great thing about Urogyn is that, we are actually helping people improve things on a day-to-day basis.
So you're in Richmond, Indiana, right? Just outside of Indianapolis. What do you find to be the bulk of the patients that you see? So you talked about that midlife area. What are the patients coming to you discussing, and what are some of the things that you're doing with them?
So the biggest thing is our age range is pretty broad. I mean, I see people from 15 to 95. So from an age range, it's probably more concentrated in the between 40 to 70-year-old group, but we do see women of all ages. The vast majority of the people in that 40 to 70 group, they're complaining of a lot of your typical, female midlife issues like, decline in hormones, decline in ovarian reserve, increase in hot flashes and sleep disturbance, and just generally having a lot of problems that they didn't have prior to the onset of perimenopause. And one of those things that's specific to urogynecology is incontinence. And so a lot of women who they were kind of going along and everything seemed to be okay initially, they get to about age 50 and all of a sudden the pelvic floor just decides it's just not going to cooperate anymore. And so people get a lot of problems with overactive bladder, stress incontinence. Those are the two biggest ones. But then also some of the connective tissue problems that goes along with aging. You get a lot more prolapse. So basically your pelvic floor getting so relaxed that the organs start to fall down. And so we deal with a lot of, those are the kind of the bread and butter topics, or, basically your midlife transition stuff, your incontinence and your prolapse.
Do you find that in your practice that you might initially see someone for incontinence, but then you also start peeling back the onion and now you see the fact that, oh, they're lacking their hormones. Oh, they also have prolapse. Oh, is that usually the typical case? What's that many times that marker that gets you that patient initially?
Yeah, I would say the majority of people come in with more than one issue. It's pretty rare that somebody just comes in and says, you know what, when I cough, I leak, and that's it. There's nothing else going on. That's literally my only complaint. And when you start to ask all of the other pertinent questions with regards to like daily function and, bowel movements and, sexual dysfunction, all of those sorts of things, they all go together because everything's in close quarters down there, right? So when one thing starts to go wrong, a lot of things start to go wrong.
And do you feel that the patient is accepting of it, or is it they're not understanding it?
I think the vast majority of people have been told or advised either by their physicians or other family members that there isn't much that we can do about it. And until recently, the conversation around, issues with incontinence, prolapse, what happens after you have a baby? Like, why is your pelvic floor such a mess? Those topics really weren't broached until probably the last 10, 15 years or so. And now that people are actually starting to discuss it a little bit more, and we're attempting to make it a little bit less taboo to actually bring the topic up, we find that people are starting to open up a little bit better about it. Now, you still have plenty of people, and especially in Richmond, Indiana, we have a large like Amish population and everything, and nobody really wants to talk about what's going on down there. So people people tend to come in, entire groups of families so that they can all have the discussion at the same time.
There you go. Well, it's interesting. So what you're saying is you can do something about it.
Oh, absolutely. Yeah. Honestly, we have a lot of options, and some of them are a little bit more on the holistic side. Like for example, like weight loss, nutrition changes, things that you have in your diet that are actually really bad bladder irritants, easy stuff like that. And that's more of a behavioral and non-surgical sort of solution. But then we also have plenty of procedural and surgical solutions, as well as some medication solutions, depending on the issues.
So what are your top 3 bladder irritants that you tell people, "Listen, you gotta cut that back."
Yeah, cigarettes, number 1. I
Okay.
could just say cigarettes 3 times because that's really the biggest one, but, also, alcohol intake and, caffeine intake. Those are usually the 3 biggest ones that you're gonna find that are gonna make a huge difference in somebody's bladder function.
And how is that affecting a person's bladder?
The bladder is a fairly fickle organ, and as we get older and we lose some of those hormones and some of, our normal elasticity in tissues, that sort of thing, what ends up happening is that the bladder becomes more sensitive over time. Um, you know, things like caffeine. Caffeine is a bit of a diuretic. It's slightly irritating. It's slightly acidic. Anything that is acidic is going to be bad for the bladder if you already have bladder issues. And then alcohol, again, you have a diuretic component to it, and it's basically going to make you want to pee more. So if you already have a problem with peeing too much, then, you know, taking in those things and cigarettes are kind of a class all of their own because, as we know, there's a ton of different toxins in cigarettes, and they affect just about every organ. If you take a look at the evidence behind, things that cigarettes can do that are not exactly desired, and with the bladder, it basically just makes the lining of the bladder extremely irritated.
What about patients that vape? Is that a safe alternative to cigarettes?
It's better than cigarettes, but I wouldn't call it a safe alternative. I mean, I am always supportive of patients that are like, "You know what? I think I'm gonna drop the cigarettes and I'm gonna try vaping for a while," and then we talk about all of the things that we can do from there. But it's still, I mean, you still have essentially chemicals and toxins that you're gonna be introducing that are irritating to the bladder.
So you spoke about surgery, taking patients back to the OR. That was one of the areas that you're passionate about. What do you find yourself doing from a surgical perspective with your patients in your community?
So obviously there's a wide range of things that we can do from an incontinence standpoint, lots and lots of different things. So stress incontinence is mostly a procedural problem because it's an anatomy issue. So it's basically you're coughing, you're sneezing, the urethra doesn't have the supports that it's supposed to have, and so it moves around too much, and then that causes the leakage. So the procedures that we have are focused on limiting the amount of that movement and basically improving the closure of the inside of the urethra when you're doing activities. So things like slings, there are different types of bulking agents that we can use, and then there are some of the older procedures that are a little bit more invasive that we don't do as often, but we still do them.
So how do you define a sling to your patients?
So a sling, a lot of people will say like, "Oh, well, I had a bladder sling," and there's really actually not such a thing as a bladder sling because it goes underneath the urethra. So I think that was just kind of a blanket term for anybody that had a prolapse repair under the bladder previously. But really, what a sling is it's a little piece of long, skinny piece of mesh tape that goes underneath the middle part of the urethra, and it basically restores support to that structure, and your tissue grows into the little holes in the mesh over the course of the first few weeks afterwards, and then it locks it into place and basically gives a new backboard to the urethra so that it's able to close shut every time you do activities again.
And so that the urethra, for the ladies that are watching, if they're not familiar, because there are a lot of people that aren't familiar with the anatomy, that's a
Anatomy.
little space, that's a little piece of, I'll call it tubing between the bladder and then where it exits at the top of your vagina, right?
Right. Right, exactly. Yes, it's the whole three-hole drawing, and I have the same drawing that I draw for everybody over and over again, but yeah, so the urethra being at the top of the vagina and level with the bladder when everything is working well, and then, rectum obviously below the vagina, and all of those things are in such close proximity, and all of the muscles around them are also in close proximity, so a lot of times one thing will go wrong and, that naturally causes other stuff to go wrong with other parts.
It's like a car, 50,000 miles, 50 years. The tires go bad, the shocks go bad, the interior needs a little, redo, and so now they're coming to see you. So you spoke about nutrition. Did was that what led you to the Tiny-Giney with regards to your slicing and dicing book that is about to get published? Can you tell us about that?
So sort of, it's evolved over time. So my friends had been asking me to write a cookbook for probably 15 years now. And I was just like, well, why would anybody want to read a cookbook that I wrote? Like, I mean, most of it's
Well, you
recipes.
must be a hit then, right? If your friends are
Well, I mean,
saying,
my friends like to eat. Yes, they
well,
they like to have me cook for sure. But I have no like real formal cooking training other than my mother was an amazing cook, and you know I grew up with a lot of great cooks, and I do a lot of lessons and watch every master class that I can and all of that good stuff. But as far as like real formal training on, gourmet cooking, I really don't have any. But what ended up happening was I noticed that a lot of patients, because we know as you eat healthier, as you eat better, and as you pay attention to what sorts of foods that you're feeding yourself that are going to affect your bladder, that people can really alter the way that they feel on a day-to-day basis. And the more cooking classes I took and the more kind of, learning about like the different sort of herbs and essences and whatnot that are actually medicinal, then I wanted to get a little bit more into, well, maybe I could recommend this particular like recipe or this particular product to a patient because it's a good replacement for their, you know, 48 ounces of Mountain Dew a day, right? Like,
Yeah. So what would that be? What's your replacement for my Mountain Dew? Because I've got 24 cans in my fridge back there.
yes. So, well, if you don't have a bladder problem, you just go ahead and do your thing. But but if you have a bladder problem, doing the every other caffeinated beverage sort of thing, I try to get people to, kind of slowly move down on the caffeine range because, I mean, if somebody told me not to drink my coffee in the morning, I'd have some choice words for them. So, I think it's just a matter of, doing things in moderation that makes sense. Um,
Hopefully, my producer's hearing this. She's 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 smiling. she's a she's,
uh-oh,
she's a Coke
he,
fan. She's a Coke. Yeah,
he's
she
got
just held
your
up her Coke.
Yeah, well, I mean, that's the thing, like, I love Diet Dr. Pepper, right? Like, it's, like, my favorite thing, but I keep 1 can in the office for desperate situations, yep.
That's right.
Um
It's only one.
Right, right. But then other than that, we talk about things that you can add to water to make it actually, taste more palatable. Whether that's something easy like, the Mio drops that you can get at the store or any of the other knockoff brands. Some of the hydration things like Nun Hydration, that sort of thing. And then I'm actually working on it towards with another company to be making another type of like mineral and electrolyte based supplement. So stay tuned on that one. Can't say much more now. But
There we go. Let's go. It's just a little teaser
yes, a little teaser, big
about
stuff on
what's
the
to come.
horizon.
So,
Yeah.
your book has been this culmination of all the places you've traveled over the years, and you've taken all these little bits of recipes. Um,
Yeah.
Only because we get to hang out in the OR, so I get to find all this fun, juicy stuff on the backside.
Yeah.
And so, what can someone expect if they pick up a copy of your book? It's going to be first and foremost bladder healthy.
Yep. Well, and I'll also point out which of the stuff in it is not bladder healthy. Like if you have overactive bladder, please don't make this recipe.
Well, there we go. Okay, so there'll be a kind of like a stoplight method. No, not for you.
Yeah. Exactly. Exactly.
So
And
what's the kind of the range of your slicing and dicing, are did you kinda lean into?
the goal is to try new things and, kind of play with your food a little bit, Um, give some ideas and tools of like, okay, I don't really like this ingredient, so what could I do with it instead? But then on top of that, I want to make it easy to cook as much as you can and preserve as much as you can, not waste a lot of food, all of that kind of stuff at home. And I did do a couple of years ago. I was post-op from my own surgery, and I decided I was bored, so I took this. It was an online course through Harvard called the Chef Program, and there's two different pieces to it, and it basically teaches you how to count calories with patients, how to come up with, dietary recommendations, kind of meet them where they are in their cooking experience. Because a lot of people, they're like, well, I mean, the most I've ever done was make Kraft mac and cheese, right?
Maybe slice up some hot dog and throw that in there for some creativity.
Yeah, exactly. A little ketchup, maybe. I don't know if you're into that. Yeah, but but so what I wanted to do was try to make it as easy as possible and say like, okay, this is the hard recipe, and then I have under time. It was like indefinite amount of time, special requirements, way too much patience. So like, don't go for that one first. Um, But I do have quite a few kind of tips and tricks to make things and storing things and prepping things and all of that easier, and that was all based on the stuff that we learned in that chef course, so
So you did take a formal class, so congratulations, you've got that certificate, right? And then you applied it to, helping people plan out their strategy of having better eating.
and then I also cheated a little bit because my sister is a registered dietitian, and her clientele is mostly, people who are diabetic trying to lose weight, people who are on GLP-1s, people who've had bariatric surgery, and kind of, the
Isn't
safe
that
ways of doing stuff and
80% of the
not, so
population, right? It's about
yeah, yeah,
80% of the population that
exactly, exactly, so it's a
are
huge
getting
group of
there,
people,
a huge group
huge
of
group of
people.
people, yeah.
So then she ensured that some of these recipes were certified.
Yes. Yeah, she makes fun of me in a couple of them, and, she's altered a few of them so that, they're a little bit more heart healthy or, like, "Hey, if you don't wanna put all this meat in your stuff, like, here's a way of making this one vegetarian."
There you go. I
Yeah.
love it. I love it. So when is this, slicing and dicing coming out?
So I'm hoping for publishing by the end of the year. We're currently in editing. So we have the Amazon people and the Barnes and Noble people looking at it and basically ripping it apart and editing it, sending it back every week. So
There we go. So, hopefully you'll get through that part of the stage, and then, of course, you'll be able to come back on the program and talk about some certain recipes or
yeah,
or we can do a
I could
live
set up
cooking
the
show.
kitchen.
Yeah,
Yeah, I could set
always
up the kitchen.
set up the kitchen. Absolutely. How has the patient population is there any difference between, where you previously were and where you're at now or, you know
So both places had a pretty big catchment area of patients. Not a lot of resources in between major cities. So, if you went north of Cincinnati, you weren't getting anywhere until you got to my old office in Dayton. And then with Richmond, it's very similar, where there's really nothing between Dayton and Indianapolis, other than the Richmond facility. So we do have a pretty wide and varied group of people. I would say probably 70% from the Indiana side, but another 30% from the Ohio side because we're basically right on the border. So it's similar as far as ages and types of people, that kind of thing. I think it just Indiana is a little bit more rural than Dayton, so it's really the only difference.
so from, like, what you like to do in your practice, what's your top 3 things that you said, "If I could do this all the time and get paid, this is the space that I love to be."
Um, so I love the menopause counseling. I love all of like the hormonal and, kind of your lifestyle type of things, counseling. The problem is that, like, as primarily a surgeon, they don't leave you a whole lot of time to do that sort of stuff. So when I get to have, my menopause clinic day and stack everybody up and talk to them about, all of the different ways that you can kind of protect yourself from not just a hormonal standpoint, but, protecting your bones, your heart, all of that sort of stuff. I love doing that. But I would say the vast majority of my practice is still going to be more surgically oriented. So, the surgeries that we do for incontinence, whether that's stress incontinence or overactive bladder, I think they're easy surgeries. So, sometimes it's really fun to just do something that's easy and quick, and you can just do 10 of them in a day and, just get done. And you're like, wow, I like stopped 10 people's incontinence today. How great is it?
Yeah, minimal complications, patients are super happy, and it's not a complex procedure. So from a menopause perspective, what do you find is the biggest misunderstanding in the patients that you see?
There is a lot of fear out there, and people just have not been well informed until really quite recently when people like Oprah started taking up the topic. It always takes the celebrities to start going through menopause in order to kind of raise the alarm about it.
Well, I've been talking about it for 2 years, and let's go, people. Come on, you know? But
I've been
I'm not
living
at
it
that
for
level
2
yet.
years, so
I'm not at that level yet. So,
I'm right around. I mean, I'm 49, so, like, I've been living it for a couple years. It's been
yes,
great. Um
exactly.
But yeah, I mean, I think the main thing is that we basically have an entire generation of women that were told that they can't have hormones, that they're far too dangerous, and that they should just kind of suck it up and get through it, and it's just a natural piece of life. And I hate that because there's so many people that still aren't up to date on it, including most physicians. Like we don't get trained on menopause, even in OB-GYN residency. I mean, I think I can count on one hand or maybe two how many lectures we had on, navigating menopause and what things are safe and where the data is. But I also went to med school back in the early 2000s when that's when the WHI study came out. And it really scared the crap out of everybody, like everybody, all of a sudden we went from 90% of women being on some form of hormonal therapy, around the perimenopause and early menopause stages to about 5%. And we're still not much above 5% because the fear factor is still there, even though the new data that we have regarding the medications that we currently use as opposed to the synthetic hormones that we were using 20, 30 years ago. We have so much more data showing that it's safe, it's effective. It really helps prevent a lot of issues that older women are, basically just prone to, like, for example, osteoporosis, cognitive dysfunction, cardiovascular issues. I mean, there's so many things that we can modulate just by having a real discussion about, like, where are your hormones at and what are we expecting now, and what other symptoms other than hot flashes are you having, because everybody thinks about hot flashes, but that's only one tiny little bit of what makes menopause menopause.
And so your message to these patients is come see you sooner, right?
Yeah.
Don't wait.
Don't wait till you're 55, 60. Like, if you're 42 and you have your first hot flash, you come right in then. We will have a chat about what the process is gonna be. Yeah,
Absolutely, absolutely.
yeah.
That's a perfect time to, let them know that there is no rule to when you go through menopause.
Nope, there's no rule, and, I mean, obviously, there's norms of, range, but everybody's process is gonna be different entirely. Like, some people won't have any hot flashes at all, they'll just, a couple days a month wanna kill the people they live with, you know? Or a couple days out of the month, they, like, can't remember their words, and they'll be in the middle of a sentence and just blank right out, and that's part of, the hormonal transition, so
So if that is happening to you and you're listening to this program, go seek out the Tiny-Giney in Richmond, right?
yep.
She will take good care of you. Now
Or
from
anybody who's listed on menopause.org.
there you go. That's a great tip on
Yeah,
menopause.org, and we
yeah,
certainly talk about it quite a bit because of the things that you reference, of from the WHI study and the fact that you weren't taught that information, and if you weren't there that day for class, that was phew, that was gone. There you missed menopause day,
yeah,
and in fact, it encompasses, 40 plus years of your life, it could be.
right,
And
exactly.
so I'm happy to see that people like yourself are, leaning into it and helping these ladies out. Um, from a a surgical perspective, what's the most complex thing that you do?
Probably amongst the most complex things we do involve, modifications from prior surgeries that didn't quite heal the right way. It's a hard way to say it. So people used to use vaginal mesh kits for prolapse repair, for example. They were mostly taken off of the market in 2020, 2021, not because they were found to be particularly dangerous, but the companies that were producing them weren't able to show that they had a superior effect to doing, regular tissue repairs with the patient's own tissue. And so because it was lacking that data, the FDA basically said these need to go. The problem with them was not the fact that they were a big piece of mesh, it was that they were marketed to be put in by a lot of people, some people who don't do a lot of pelvic floor surgery. And so there were a lot of people who were getting these mesh kits being, with like a world of promise of you're never going to have a prolapse again, and this is super safe and it's going to improve everything. But they also caused a lot of bladder dysfunction. Some of the mesh would erode into the vaginal tissue, and then that causes a problem with, length and, not having enough good tissue to be able to restore the normal anatomy after you take the mesh out. And so some of our more complex things involve removal of mesh from both the vaginal wall, sometimes the bladder, sometimes the rectum. There's a lot of different places where it can lodge itself that it shouldn't be. And so those are probably the most difficult cases because a lot of times they require vascular flaps and a lot of reconstruction.
Yeah, and but there is hope for those particular ladies, so that's always, a good thing for them, that they have someone like yourself who's done a fellowship and has trained in that space, and that's really your focus is to be able to handle, 10 slings for stress urinary incontinence a day, and then also on the far end, the most complex,
Yeah,
mesh
a good
removal.
a good 5-hour dissection.
Exactly. So if someone says, "Hey, I want to avoid surgery," what are some things that you do in your practice if they say, "I'm not really ready for surgery right now, but I wanna improve my current condition?"
Yeah. Quite a few things actually. And we're definitely a fan of trying, conservative therapies first. Because a lot of people will get enough relief out of it that they can put surgery off for another couple of years, even if they have significant issues. So, for bladder health, obviously dietary changes are going to help. Avoiding those irritants, weight loss also will improve your bladder function considerably, and there's been a number of studies showing that. But then also pelvic floor physical therapy, which I mean, they're pelvic floor physical therapists are some of my favorite people. They're like magicians. I mean, I don't I understand the concepts of what they do, but the amount of relief that they give to patients, with regards to stress incontinence, overactive bladder, chronic pelvic pain, like variety of other things, they really do an amazing job at minimizing the symptoms and teaching the patients, the necessary tools that they need in order to keep things at bay.
So those areas, and then should you use, physical therapists, like, before surgery, after the surgery? What's your normal protocol?
There's so I always tell people about physical therapy before surgery if they're, kind of gung ho about going the surgical route, that like that week, if there's anything left over that's a complaint with regards to bladder leakage or, pelvic floor symptoms, pelvic pain, that kind of thing, that physical therapy can be used at that point to just kind of tee up and fix the little stuff that's left. Um, there are some people though that, you just say like, listen, if you're really not ready for surgery, we do the PT first. We see how much relief you get from it. Regardless, it's going to help with your symptoms. And then if you decide down the road that you want to do PT, then that's great. There's some data showing that after delivery, that most people should be at least told about pelvic floor physical therapy in case things arise, because there's a lot of people that are walking around that are within a few years postpartum that are having a lot of bladder issues, and they've really been given, no advice and no resources for the leakage, the pain, that kind of thing that happens afterwards. So yeah, so I mean, anytime anybody wants to do pelvic floor physical therapy, I've never said no. I don't think that's something you should do.
It's a positive, right?
Oh, they're great. Yeah.
So if people that are listening and they might have younger, kids in med school, and of course you did a fellowship, what would you how would you say to someone that's in medical school or in the residency, what did the fellowship program do for you, uh, personally and professionally?
So fellowship is basically, I mean, it's an extension of residency. The main difference being is that you already finished your residency, so you have a full license. Whereas in residency, it's a provisional license specifically for residents, because you're still being overseen by somebody who's helping train you. The fellowship for urogynecology is an additional 3 years on top of the 4 years of OB-GYN residency. Um, it's really, I mean, I think the main thing that is remarkable about it is that, especially if you're in a high volume fellowship like I was, you're operating almost every day. You're both operating and in clinic almost every single day. You have an amazing amount of research opportunities that you can do to kind of hone into like where you want your practice to go in the future. Um, you know, I think just the volume in general of the things that you see, the complications you see, and a couple of different bosses do a world of good at teaching you how you would like to move on and actually operate yourself. So I think about the four people that, were my bosses in fellowship, and the things that I've taken from each of them, and, even ways of counseling people, that sort of thing. So you get to pick and choose and decide, like, this is what I want my kind of signature way of practicing to look like.
That's great, and I think it, you know, s sounds like you enjoyed your experience. It has set you up for success, and certainly you can see it in your practice because you are extremely busy.
Yeah, a
Uh,
little busy.
so from a busy standpoint, where do you put in your activity and you're getting ready to go volunteer and, you've got all these other things going on. How does someone, especially, because we have women that watch this program, what do you do, to keep yourself sane?
I don't know if I do keep myself sane, but, also in medicine, it's completely fine to be a surgeon and not be quite sane because that's sort of expected. So, but as far as, how do you make it so that you have a little bit of time to do other things? I mean, urogynecology is a much nicer life balance than, for example, regular OB-GYN. I don't do 24-hour call shifts at the hospital waiting for babies to show up and doing C-sections at 3 o'clock in the morning. Like I don't do any of that anymore. So, yes, you have call, and, yes, you do have some late days and that kind of thing. But for the most part, you can decide, this is how I want my practice to look, and this is how I want to work it. And then, kind of as you get a little bit more into practice, I mean, I've been out of fellowship for 13 years now. So, I've kind of gotten to the point where I have enough free time that I can explore some of the other stuff that I want to do, like, the cookbook and my aesthetic side stuff and all of that. So,
You got it pretty well dialed in, and you're actually, you're also in, fantastic shape. So you've got some exercise built in there somewhere. Or are you just eating really well?
no, well, I mean, I do eat well, but no, I mean, I've always been a little bit of an exercise freak, and I was a bodybuilder long, long time ago and all that good stuff. So we got rid of that. That was too much work. But
Yeah, talking about a commitment, right?
Yeah, no, I can't be at the gym for 5 hours a day.
No, no, most likely not. From the
Right.
from I'm curious because I've had some time with you in the operating room. How do you um, see or how do you utilize biologics within your practice? Um, as patients that watch the program, they know that we have biologics that we utilize and have brought to market. So, for you personally, how do you place them in your practice?
Yeah, so biologics, it's a great extra tool, especially for complex cases. Like I was talking about with the crazy mesh removals and not sure if you're going to have enough tissue left over, that kind of thing. Um, a lot of times biologics can be used as just that extra layer of protection. And, you know, you never want anything to be under too much tension when you're doing a surgery. That's kind of like one of the number one rules of management of tissue during surgery is that you don't want the tissue to be under a lot of tension. And if you think that there is going to be that kind of tension, or you think that there are risk factors for healing that are significant, then, adding biologics into that picture does a world of good in the recovery period.
Thank you for that because I think that's important for people to understand. And of course, physicians utilize biologics differently. And so I always appreciate everyone's insight. And with that, Dr. Evans, we thank you for being on VNEW Health and sharing your time and some of your stories and some insights. And we're excited to have an opportunity to see your book here in the near future.
Yeah, me too.
So, Dr. Evans, thank you once again for joining us and congratulations on the cookbook and your very successful practice. If people want to engage with you or follow you, how will they do so?
So a couple of different ways. So on Instagram, my page is Tiny-Giney MD. So it's Tiny Tiny Gynie GYNIE MD, and there's also two websites that I contribute to right now. The one for the book is still under development. The first one is my travel blog, and it's tinygynytravels.com. And so even if you just need some advice on where to go in Spain or something like that, you can find some information there. But it also has some references to the cookbook timeline and where we're at with it. And then the other website is Stabby Chic. It's Stabby, STABBY. Chic is CHIC.net. And that is my side business for wellness and aesthetics. Includes information on the cookbook, all of my aesthetics things that I do, and then also my sister's information with regards to her dietary business.
Super. Well, thank you once again. And of course, if you liked today's show and our previous shows, don't forget to hit the like button, subscribe down below, and share it with your friends.